Good afternoon, gentlemen, and let's see how we can diagnose and prevent and treat a painful and a stiff knee in 2018. The definition first, as per international consensus on fibrosis of the knee joint, this has come out in 2016. This is a new definition, and the arc of movement, if it's between 10 and 90, that's a mild stiff knee. If it's between 20 to 80, that's moderate stiff knee. And if the FFD is more than 20 and the arc of movement is less than 70, that's a severely stiff knee. It occurs in less than 1 to 3%, but is underreported. And the reason is that all the registries don't report on stiff and painful knees. And all the revisions for stiff knees are also not recorded in registry data. And that is why the incidence is less reported. This particular patient, as you saw in the video, was 10 to 90, swollen, painful, and stiff. Pre-op causes could be inflammatory patients, post-traumatic arthritis who have previously limited pre-op range of movement, and diabetics who inject insulin on the thigh have been shown to have predisposition for fibrosis. So we have to advocate them to use insulin on the abdomen and not on the thigh. Also, they have to reduce the smoking if they are smokers. Intraoperative factors, coronal malalignment, especially if you left the knee tight in extension, may cause a FFD. Overstuffed joint and excessive joint line elevation and a poorly aligned prosthesis. On the sagittal front, if you have an upward slope, that may tighten your flexion gap. If you have an oversized prosthesis, especially in flexion, that will tighten up the anterior compartment and lead to a stiff knee. On the axial side, if patella is maltracking or is overstuffed, then you will have poor range of movement and a stiff knee. Post-operative factors, poor pain control, suboptimal post-op rehab, hemarthrosis or infection can all lead to a stiff and a painful knee. But what is more important is to understand this term called arthrofibrosis, which has been redefined now as post-surgical fibrosis. And bands of scar tissue between the cord mechanism and the distal femur are the main cause of a stiff knee if the component malalignment has been ruled out. One tip is to carefully see for patellofemoral mobility. If the patella is mobile in the femur nicely, then there is not arthrofibrosis but malalignment in any of the three components. For that, we need to understand the scar formation mechanism. And whenever there is a post-surgical insult, fibroblasts proliferate in the scar area. And there is platelet response and stimulation of neoangiogenesis. If the fibroblast proliferation is exaggerated, then there is more formation of type 1 and 3 collagen, and that leads to increased scar formation. And there are some patients who have predisposition for more scar formation, more collagen formation, and that can all lead to a stiff and a painful knee. What about the management? There are 4 pillars of management for a stiff and a painful knee. First, mobilize the patient. Second, manipulate under general anesthesia. Third, lysis of adhesions. And 4, revision arthroplasty. Let's see them one by one. If you see the patient less than 6 weeks, that's the case for mobilization of patient. And you can initially do the RICE treatment, which essentially means rest, ice compression, and elevation. Take the patient into confidence, get them to supervised rehab in the hospital, and ensure that they are in the counseling areas every day and you do good rehab for them, and CPM does not help in these cases. Manipulation under anesthesia is for patients who still have stiffness from 6 weeks to 3 months. Beyond 3 months, do not try manipulation under anesthesia because the risk of iatrogenic fracture increases. There is a tip for manipulation that the hip has to be flexed and your hands have to be just under the knee and not on the ankle. And you can also take your arthroscopy colleague into confidence. If the knee is not really manipulating, he can do a lysis under anesthesia. Take the PCL off if it's a CR knee, and then again you can manipulate after he has lysed all the adhesions arthroscopically. Lysis of adhesions has to be within the 3-month window period. And these are borderline cases, and you can mix with manipulation with the arthroscopic lysis, where all the adhesions have to be released, especially under the patella onto the femur, and then you can again manipulate very gently, carefully under anesthesia. But this all has to be done within a 3-month window period. So you have to follow these patients very carefully. Open arthrotomy, you have to do a complete synovectomy, remove all the scar tissue, clear the gutters, both medial and lateral, remove the poly insert and maybe use a thinner insert, provided that does not cause instability, and lateral retinicular release to ensure that there is increased quadriceps compliance. But the mainstay of treatment is to remove all this scar tissue, clear the gutters. Revision TKA is indicated if after 1 year the patient is still stiff and painful, and you have to correct the fixed flexion deformity and do a sloppy revision. That means use a thinner poly, especially in flexion, because these patients are never going to go beyond 90. So leave them a little loose, correct the fixed flexion deformity, and you may have a good result. So friends, this is the take home for preventing stiff and painful knee. Do not operate early. Do not operate without bone-on-bone disease, because these patients may develop painful stiff knee. Optimize patient factors, diabetes and smoking. Do not overstuff the joint in any of the 3 planes. Adequate pain control and rehab. Take home for treatment within 6 weeks, aggressive physiotherapy after 3 months, lysis of adhesions after 1 year, revision TKA. Newer frontiers of research are these molecules, anakinra for this interleukin-1 receptor antagonist, low-dose irradiation, and botulinum toxin. Thank you very much.